Hi, I'm Dr. Brian Jenkins, the founder and president of Doctors in Training and the primary educator for the DIT Step 1 review. By now you should have received 15 questions to help you begin your Step 1 or Level 1 study process. 15 new questions will be posted every Monday and Thursday from now until May 3rd. These questions are going to encourage you to study for the Usmle Step 1 and Comlex Level 1 exam now, and they are also going to help you learn the high-yield information actively rather than passively. This means that you solidify the actual synaptic connections in your brain by having the learned information flow out of your brain in some manner, be it speaking or writing or drawing. So over the last 2 years, there have been many advances in the neurobiology of learning, and we are employing these advances in order to maximize your retention of high-yield Step 1 and Level 1 information. And as far as I know, we are the only Step 1 review in the world to actually be implementing these advances in learning. At this point in your Step 1 or Level 1 study, I recommend that you spend about 10 to 12 hours a week reviewing and studying for the exam. But do not neglect your present coursework. As you may already know, the best way to study for Step 1 is to do well in your current coursework. So at the bare minimum, I recommend that you go through these twice weekly questions and video answers. I also highly recommend finding a study partner to keep you on track and make your learning more active rather than simply reading to yourself. Quiz each other with these DIT Part 1 questions and pimp each other with new questions as you go through your Step 1 review book, such as First Aid. As you know, First Aid comes out with a new edition annually. Because it has been requested to us by our students, we will tell you where you can find many of the answers to these Part 1 questions in both the 2011 and 2012 edition of First Aid. But as you may recall, we've always said that although you need to use a high-yield review book, such books will only get you about 65% of the way to your peak Step 1 score. So in your Part 1 questions, you will also find 2 questions that do not have answers to First Aid. In First Aid, these questions are high yield, and the answers to these questions can be found in other sources we have cited for you. We want to make sure that you guys have access to all the high yield information for Step 1, not just that 65% of the information. We are really excited also this year to be able to provide you with these video explanations to these answers. This will help you stay on task and also help make sure you're integrating the information actually in your brain correctly. But don't slack off. Even though we're giving you the answers, you still need to try to answer the questions on your own and attempt to find the answers when you don't know them. This interaction with the information is essential to help you know what you do and don't understand. Learning, it's a process, and it is not simply about getting the answers. The last thing I want to mention before we get started with the answers is that if you do not already have a week-to-week plan of how you will study for Step 1, you need to make one. And if you're having trouble or want a little hand-holding, please purchase some time with one of our very experienced student advisors who will walk you through your schedule and tailor a Step 1 study plan exactly to your needs. And now let's proceed with answering your first set of questions. Number 1, 5-alpha reductase deficiency leads to what physical findings in a male? In this disorder, there is no 5-alpha reductase enzyme to convert testosterone to DHT. So some of the external manifestations you'll see is that these males have ambiguous genitalia until puberty. Then at puberty, as testosterone levels increase, the external genitalia such as the penis develops, and they get secondary sex characteristics as well. Internal structures such as the testes, epididymis, and prostate are present and normal throughout their lifespan. Next, you start a patient on a drug that has been on the market for 5 years. It has excellent efficacy. However, your patient begins to have an annoying side effect 1 month after initiation of this drug. She contacts the manufacturer about it, and they in turn contact you to gather data on her course while on the drug. In what phase of the clinical trial would this example fall? So there are considered 4 phases of a clinical trial. Phase 1 assesses the safety of the drug on normal patients. Phase 2 determines if the drug actually works on diseased patients. Phase 3 is the head-to-head trial with another drug. Phase 4, which is the phase referred to in this question, is the post-marketing surveillance of a drug after the patents have been approved. All right, next question. A 12-year-old male is taken to the ER for confusion associated with vomiting and abdominal pain. On exam, you note a fruity breath odor and that the patient is experiencing rapid deep breathing. The patient's random blood glucose is 522 milligrams per deciliter. What condition is this patient experiencing? Most of you probably got that this is diabetic ketoacidosis. The rapid deep breaths are Usmle's respirations or Usmle's breathing. What ketone is the cause of the patient's fruity breath odor? Acetone, which is created by the spontaneous conversion of acetoacetate. Which ketone body is detected by the urine test in diabetic ketoacidosis? In the urine test for ketones, you're going to detect acetone and acetoacetate. You will not detect beta-hydroxybutyrate. So there's 3 ketones you need to know: acetone, acetoacetate, beta-hydroxybutyrate. Only 2 of those 3 are going to be identified on a urine test. Next question. Aztreonam and penicillins both bind to penicillin binding proteins. Can aztreonam be used in patients with penicillin allergy? It is a cell wall inhibitor, just like penicillin, so you might suspect no, but the answer is yes. There's no cross-reactivity with penicillins. And the next one, in which patient populations is aztreonam a good choice? Well, we just mentioned if the patient is penicillin allergic, or in patients that have renal insufficiency that you would want to give an aminoglycoside to. Which brings us to the next question. Against which organisms is this antibiotic effective? Gram-negative rods only. So, gram-negative infection in a penicillin allergic patient or in a patient with renal insufficiency that you can't use aminoglycosides, consider aztreonam. Next question. 32-year-old man is in the hospital for a minor vehicle crash. Overnight, you're called by the nurse because the patient's blood pressure went from 125/80 to 201/111 and now is tachycardic. The patient now appears diaphoretic and reports feeling a little anxious. Though he says that this happens once or twice per week, suspecting the diagnosis, you check his abdominal CT scan, which does, in fact, show an adrenal mass. What alpha-adrenergic antagonist should be used to treat this patient? So this is obviously a clinical scenario in which the patient has an adrenal pheochromocytoma that is secreting catecholamines, causing sympathetic symptoms such as hypertension, tachycardia, diaphoresis, and anxiety. The alpha antagonists that can be used to control the hypertension are phenoxybenzamine and phentolamine. If you wanted to control the tachycardia, those drugs are not going to affect the heart. So what drug would you use, or what drug class would you use to control tachycardia in a patient that has excess sympathetic drive? Go for a beta blocker. Right, the next question, how do primary and secondary hyperaldosteronism differ in their effect on plasma renin levels? Primary hyperaldosteronism caused by an aldosterone-secreting tumor decreases renin by a negative feedback mechanism. So aldosterone-secreting tumor, negative feedback on renin production, so you have low renin levels in primary hyperaldosteronism. In the secondary hyperaldosteronism, this is caused by the JG apparatus of the kidney perceiving a low intravascular volume, and that would create an elevation of renin. So that JG apparatus is going to shoot out renin or elevate renin levels, and that's going to cause your hyperaldosteronism in that case. Next part, what agent is used to treat primary hyperaldosteronism? Well, you're going to use an aldosterone antagonist, which is spironolactone. Spironolactone falls in the category of a potassium-sparing diuretic. Specifically, this potassium-sparing diuretic works by acting as an aldosterone antagonist. Next question. 35-year-old G1P0 has been hospitalized for observation of vaginal bleeding from a placental abruption. Her most recent labs represent an increase in the bleeding time, which is a platelet problem, an increase in the prothrombin time, and an increase in the partial thromboplastin time. You're concerned this patient might be at risk for disseminated intravascular coagulation, which is DIC. What is this patient's risk factor for having DIC? Well, in this case, it is placental abruption. So know that placental abruption is a risk factor for DIC. What additional risk factors and lab findings are associated with DIC? There's a great mnemonic for DIC, which is stop making new thrombi. S-T-O-P-M-N-T. Stop making new thrombi is mnemonic. The S is for sepsis. The T is for trauma. O is for obstetric complications such as eclampsia, placental abruption like we just mentioned, or amniotic fluid embolism. The P is for pancreatitis. The M in making is for malignancy, can cause DIC. The N in new is for nephrotic syndrome. And the T in thrombi is for transfusions, which can also cause DIC. What lab findings would you see? The platelets get consumed. This, of course, causes thrombocytopenia or low platelet count. And also, you're going to see an elevation of bleeding time because of this thrombocytopenia. Clotting factors are going to get consumed as well, causing an elevation of PT and PTT. You're going to have decreased fibrinogen, decreases in factors 5 and factor 8, and there's an increase in fibrin split products. Specifically, we measure D-dimers to help us identify whether there is DIC, but it's certainly not specific for DIC. There are other things that can elevate D-dimer other than DIC. Next question. 43-year-old male complains of right-sided facial drooping. When you examine the patient, you notice an upper and lower face drooping. This is a good sign. Does this patient have a lower or upper motor neuron lesion? All right, so the lower motor neuron lesion, there's going to be a lower motor neuron here in the facial nerve, which is the facial nerve and nucleus, which innervates both the upper and lower face, right? So if you, the upper motor neuron regions, such as the facial region of the motor cortex, innervate only the contralateral lower face and the bilateral upper face. So upper motor neuron lesions would result in a spastic paralysis of only the lower face because the upper face is receiving innervation from both cortices. But if you obliterate the facial nerve or facial nucleus to one side, that is going to affect both the lower and the upper face. Consequently, if you have a patient that comes in with facial drooping and it's the entire face, they can't smile, they can't shut their eye tightly on that side, and they can't raise their eye, can't wrinkle their forehead on that side, that's a good sign that you're not dealing with stroke, but rather dealing with an isolated lower motor neuron lesion, such as could be caused by Bell's palsy. So what diseases are associated with Bell's palsy? Well, by and far, it's usually idiopathic. It's not caused by anything in particular that we are aware of, but it can be seen as a complication of AIDS, Lyme disease, HSV or herpes simplex, sarcoidosis, tumors, or diabetes mellitus. Next question. What are the important functions of vitamin C? It's real important to know about vitamin C for step 1. First of all, it can facilitate iron absorption. So if you have a patient that's iron deficient that's going to be taking iron, administering that iron with vitamin C could be helpful. Most importantly to know for step 1, it is necessary for the hydroxylation of proline and lysine in collagen synthesis. Right? No vitamin C, no hydroxylation of proline and lysine, no collagen synthesis, and you get what? Scurvy, right? But one other thing you need to know about vitamin C is it's necessary for the conversion of dopamine into norepinephrine. All right, so 3 main things to know about vitamin C and what it does in our bodies. Next question. A physician, while working with a humanitarian aid organization in Africa, is seeing a 30-year-old male patient with HIV. The patient complains of fever, weight loss, and a cough associated with hemoptysis over the past 2 months. The chest X-ray reveals perihilar. This is lymphadenopathy around the hilum of the lung, and a left lower lobe granulomatous formation. What is the name of these X-ray findings? This is referred to as a Ghon complex, G-H-O-N complex, which consists of hilar lymphadenopathy plus granuloma in the lung, and that granuloma in the lung is called a Ghon focus. So Ghon focus plus hilar lymphadenopathy is the Ghon complex of Mycobacterium tuberculosis. What other mycobacteria species cause pulmonary disease? Not necessarily the Ghon complex, but other pulmonary disease. There's Mycobacterium consacii and Mycobacterium avium. What are the potential extrapulmonary manifestations of Mycobacterium tuberculosis? Now, you may know that TB has been called the great imitator in the past, and it can cause various problems in just about any organ. A few to highlight, though, are CNS manifestations of TB, which include parenchymal tuberculoma. Also, TB meningitis is actually pretty common in the TB population. Vertebral body infection with TB is going to cause Pott's disease. Lymphadenitis, obviously, is very common. You can also have renal infection of tuberculosis and GI infection of tuberculosis. Next question. The neonatologist you're working with on your pediatrics rotation suspects a newborn to have DeGeorge syndrome. What is the underlying cause of DeGeorge syndrome? So with DeGeorge, fundamentally you have a thymic aplasia. Right? Your thymus never forms. This is usually due to a gene deletion on chromosome 22. As a consequence, the endodermal-derived third and fourth branchial pouches fail to develop, resulting in the thymus and parathyroids failing to develop. Obviously, you need your thymus and parathyroids. So what are the manifestations of DeGeorge syndrome? Well, you're going to get tetany, because without PTH from your parathyroids, you're going to get a hypocalcemia. You're also going to have recurrent viral and fungal infections, since T cells can't mature in the thymus. And if it's a deletion of chromosome 22q11, this is referred to as a catch-22 syndrome or catch-22 deletion. You may also see a few other things, including cleft palate, abnormal facial features, and congenital defects of the heart and great vessels. So those are all things associated with DeGeorge. Next question. Amyloidosis and sarcoidosis are associated with which cardiomyopathy? This is a restrictive or obliterative cardiomyopathy. Anytime you bulk up a tissue with a substance such as amyloid or granulomas of sarcoidosis, you will restrict the function of that tissue. It's not designed to be that bulky. What are some other diseases or conditions associated with this kind of restrictive or obliterative cardiomyopathy? You don't need to know all the causes. You pull out Harrison's, you look it up, you're going to see a whole table with lots of different things that can cause restrictive cardiomyopathy. But there are a few worth knowing for step one. And they are a post-radiation fibrosis, endocardial fibroelastosis, Loeffler's syndrome, and hemochromatosis. In all these cases, you're restricting the function of the tissue by making it abnormal tissue in some way. Next question. A patient of yours with recent complaints of weakness, pallor, craving for ice chips, and tachycardia has a history of chronic hemorrhoids. What do you immediately suspect is the cause of this patient's anemia, and how do you treat it? This would be an example of pica, which is a craving of non-food substances, such as ice chips or laundry detergent as a classic example also of pica. Pica is a feature of iron deficiency or iron deficiency anemia. Here, the chronic hemorrhoids is a flag for rectal bleeding, which may be the cause of the iron deficiency. The treatment, obviously, would be iron replacement. And how can you augment the absorption of the iron replacement? With vitamin C, right? Possibly also, this patient would need a colonoscopy to evaluate the patient for colon cancer, even though they have hemorrhoids, but especially if the patient is any patient over age 50 with iron deficiency anemia, you got to give them a colonoscopy. Next question. How is the body affected by a prolonged stay in space at zero gravity? This may seem like a silly question. Space medicine, aerospace medicine is actually important to know for step one, so don't overlook this topic. So what would you see? You're going to see a decrease in blood volume, a decrease in red blood cell mass, a decrease in muscle strength and work capacity, a decrease in the maximum cardiac output, and a loss of calcium and phosphate from the bones, and a loss of bone mass. So all these things can be found in astronauts after they've been in space for an extended period of time when they return back to Earth. What are the most common viral causes of myocarditis? In the United States, this is the Usmle, so we don't need to worry too much about worldwide causes of myocarditis. U.S. causes are most important for the United States medical licensing exam, also for your COMLEX exam. But in the U.S., the most common cause of myocarditis is viral infections, and the most common agents are Coxsackie viruses A and B, as well as echovirus. Make sure you know those. Additionally, less common causes of viral myocarditis include influenza, HIV, and CMV. So the main three, again, are Coxsackie A and B and echovirus. And additional 3 to know are influenza, HIV, and CMV. All right, that's it for these questions. Thanks, guys, and I'll see you next time.